Good evening. Welcome to our Franciscan Health Education webinar series. I'm your host, Stephanie Nichols, Marketing Director at Franciscan Health. I'm excited for our team to share some great information on COPD and our newest treatment, the PulmonX Zephyr valve, which Franciscan Health is only one of very few hospitals in Indiana to offer this to patients with severe emphysema. This evening, our experts will help you better understand what is COPD and emphysema, who is eligible for the Zephyr valve, what results can be expected from the procedure, what does the recovery look like, and why choose Franciscan Health for my treatment. Before we get started, I'd like to share a few housekeeping items. For this virtual event, participants are muted. We ask that you remain muted to help us avoid background noise and interruptions. If you have any questions to ask the presenter during the presentation, please type them in the chat window. We'll be answering your questions at the end of the webinar. Kirsten is our administrator who will be taking care of everything on the back end. So if you experience any technical issues, just type them into the chat window and we'll work to resolve them. If you miss anything, no need to worry. We'll send out the recording of tonight's presentation to you in a follow-up email, along with some great resources for you to download on today's topic. Franciscan Health is home to some of the country's most well-respected physicians and clinical specialists. I'm excited to introduce you to our pulmonary nurse practitioner, Abby Ertl, who will discuss how a one-time minimally invasive bronchoscopy procedure could improve the quality of your life with less shortness of breath and more energy. Abby has been with Franciscan for 8 years, first as a registered nurse and subsequently a nurse practitioner. She joined the Interventional Pulmonology Clinic in 2019, where in collaboration with Dr. Khan, our interventional pulmonologist at Franciscan Health, Abby evaluates and treats patients with pulmonary nodules and those with severe COPD who express interest in endobronchial lung volume reduction. And later you will watch a video and hear from Dr. Khan, our interventional pulmonologist with Indiana Internal Medicine Consultants and Interventional Pulmonology Clinical Medical Director at Franciscan Health. Dr. Khan received his medical degree from King Edward Medical College in Pakistan in 2001 and his internal medicine residency at Southern Illinois University in 2006. In 2009, he completed a pulmonary and critical care fellowship at Indiana University. Dr. Khan is board certified in internal medicine, pulmonary, and critical care, and is one of only 4 board-certified interventional pulmonologists in Indiana. Dr. Khan began practicing at Franciscan Health in 2019, and a few years later provided the vision for an interventional pulmonology program at the hospital. The comprehensive program implements innovative diagnostic and procedures for evaluation, staging, and treatment for complex lung diseases in one convenient location for diagnostics, clinic, and procedural and follow-up appointments. The clinic serves as a consulting service for providers, where multidisciplinary team approach is provided by Dr. Khan, the program's pulmonary nurse practitioner, Abby, and pulmonary nurse navigator, Laura Halterman. Before we get started, let's better understand our audiences. And so let's go ahead and do a poll question. Please go ahead and complete this seminar of why you are attending this evening. I'm a former smoker. I have recently been diagnosed with COPD or emphysema. I want to know which treatments are available for COPD and emphysema, and I'm attending for a friend. All right. Okay, it looks like we have a variety of people here today, of all different smokers and former people with some emphysema and COPD, people diagnosed with emphysema and COPD. So this will be great. Abby will have a lot of good information to share with you guys. Now, without further ado, please welcome our pulmonary nurse practitioner, Abby Ertl.
Thank you, Stephanie, for the introduction. So let's just get into it. What is COPD? COPD is a chronic lung condition that includes chronic bronchitis and emphysema. People can have one of these or a mix of both. COPD can cause a variety of symptoms, including wheezing, shortness of breath, and cough. It is progressive and not curable, although medications can help provide relief of the symptoms. Approximately 1 in 17 adults in America have COPD. That is about 15.5 million Americans, and millions more have it and don't even know. Most specifically, let's talk about emphysema, because the procedure we will be discussing today only treats this type of COPD. Emphysema is damaged lung tissue. It is commonly caused by smoking, but it can also occur from frequent inhalation of chemicals or environmental toxins. It can also be caused by alpha-1 deficiency, which is a genetic condition. Emphysema affects the air sacs in your lungs and causes them to trap air in as you breathe, causing persistent breathlessness. This picture is representative of those enlarged air sacs holding air. Air trapping and hyperinflation and emphysema. In healthy lung tissue, the air sacs are small and inflate and deflate with air as you breathe, giving a person the ability to take deep breaths in and out. But when you have emphysema, these air sacs are damaged, floppy, and make it harder for your lungs to move the air in and out. The damaged air sacs, as mentioned above, actually hold on to air, and we call this air trapping. That trapping causes your lungs to become bigger over time. So those overly inflated lungs place pressure on your diaphragm, which is also your breathing muscle, and that squishes the healthier parts of your lungs as well. So this causes shortness of breath, especially with activity. The top picture shows healthier lung tissue on that side of the chest, and the other one on the bottom shows damaged.
Okay, that's some good information so far, Abby, but let's go ahead and take a poll question to test everyone's knowledge. What are the effects of air trapping? Increased activity, low risk of mortality, or none of the above? All right. Let's see how we responded. Increased activity is what most people chose, or some people chose. None of the above is the correct answer.
That's great. Okay. So statistically, 453,000 people in Indiana have COPD, but not all of these patients are effectively treated, which is why it is always good to speak to your lung doctor about your management options. In the recent past, this was the spectrum of treatment options available for those with emphysema. So after optimizing medication management and attending pulmonary rehab in some cases, the next option was to consider lung volume reduction surgery or lung transplant. But both lung volume reduction surgery and lung transplant have extensive recovery processes. Now we have the option to treat patients through endobronchial lung volume reduction utilizing Zephyr valves. They are tiny implantable devices with benefits similar to surgery, but with no cutting. They are actually placed through the windpipe into the lung under general anesthesia. With precise patient selection criteria, we can choose which patients will most likely benefit. The valves are proven to be clinically effective through the results of multiple studies and are now part of medical guidelines for management of emphysema. Lastly, these devices are fully removable if need be. Otherwise, they are a lifelong treatment. Again, this shows you where the valves fit into the spectrum of treatment options that we just talked about. So once you're on a good inhaler regimen and active in pulmonary rehab, you can consider this procedure as a next step option before the other invasive ones. So how the Zephyr valves work. So where these boxes are, we're actually going to watch
the Zephyr endobronchial valve.
And the videos are going to show you how the valves work. So Zephyr valves will occlude one lobe of your right or left lung, ideally the most distracted lobe with the greatest evidence of air trapping. And the occlusion of the targeted lobe causes it to collapse, which makes more room for the rest of the healthier lung tissue on that side of the chest to expand and subsequently reduce pressure on the diaphragm to allow for easier breathing. So let's just take a look at that.
Valve is a proven, minimally invasive treatment designed to improve breathing, activity, and quality of life for emphysema patients who are breathless despite maximum medical therapy. The Zephyr valve procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. The valves can be removed and replaced if needed. After treatment, the remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function. Patients who respond to Zephyr valve treatment often experience meaningful improvement within 45 days.
Okay, and then we're going to look at a second video here. And this is going to show you as a person breathes in and out, air escapes out of the treated lobe, but does not enter back in, keeping it collapsed. And this is with the one-way valve. So again, as they're breathing in and out, the air is coming out of the treated lobe. And when they breathe in, that valve closes. So Zephyr valve benefits start with a successfully treated lobe as a basic foundation. And once that has been accomplished, there's reduced air trapping, which is what we've been discussing through this presentation so far. And so in turn, that improves lung function and reduces breathlessness. Of course, this leads to an improved quality of life and exercise tolerance. And, if we feel better and can move better, then that overall improves health status. Patient selection criteria. So essentially, this encompasses 6 parts, and the initial qualifying criteria for the procedure is seen through evaluating pulmonary function testing, a 6-minute walk test, and a CT scan showing moderate to severe emphysema. And with that CT scan, we will talk about StratX, and that will be in the coming slides. But these tests identify the severity of COPD and give us insight into basic lung function. We do have a specific range of numbers we look at, as noted here on the slide under the orange. So if you are outside of those numbers on your PFTs, you could be too healthy for the procedure or too severely declined that you would also not benefit from the procedure. So after looking at these top 3 tests, and if you're within parameters, we move on to evaluating an echocardiogram for heart health. And with that echocardiogram, we look for pulmonary hypertension or congestive heart failure, which are 2 conditions that, if severe enough, would disqualify someone. We also look at an arterial blood gas to evaluate for high carbon dioxide levels or severely low oxygen levels in the blood. And split perfusion testing maps out the area of your lungs that are getting a lot of blood flow versus those that aren't, to ensure we are treating unhealthy parts of lung. We do not want to treat healthy parts, of course. Pulmonary rehab. So this is an essential component of this entire process. If not enrolled when referred to us, we have each candidate attend 12 sessions prior to the procedure and at least 12 sessions after. The benefits of pulmonary rehab include improved stamina, exercise tolerance, reduced perception of breathlessness, strengthening of respiratory muscles, including that diaphragm that we talked about, and overall does improve the outcomes of this procedure. Smoking status, also, you have to be a non-smoker for at least 6 months, and we do nicotine testing to ensure that. Okay, and as previously mentioned on the slide of tests needed to qualify, we want to look at pre-screening with StratX. So each CT scan that shows us adequate emphysema gets submitted to what we call the StratX system. And this is a computer-based system that analyzes all of the lobes of your lungs and the separation between the lobes of your lungs. And we actually get a printout of this to review, as you can see on the slide here. So your right lung has 3 lobes and your left lung has 2 lobes that make up your anatomy. If the report shows a lobe or lobes of the lung with greater than 50% emphysema destruction and with greater than 80% complete fissures, and we will talk more about fissures, Those are the separation between the lobes of the lung. Then with these criteria, then they could be good targets for lung volume reduction. You will hear us use the term of collateral ventilation. In our world, you will also hear it called CV, and we are talking about the fissures in your lungs when you hear this. So again, the fissures separate the lobes of your lungs. Collateral ventilation means communication between the lobes. So think of it as a wall with holes versus no holes, or a solid wall versus a wall with open windows. And this is important for the success of this procedure. If there are communication channels or holes between the lobes, then treating that part of the lung would not result in collapse. It would just continue to fill with air from other parts of the lungs, and the procedure would be unsuccessful. You would be considered CV positive or collateral ventilation positive if that is the case. If not, you would be considered CV negative, which means little to no collateral ventilation. Only lobes with little to no collateral ventilation can be treated with Zephyr valves. We evaluate this on the StratX report, but also on the day of the procedure with a test as well. So there will be a video here, but I wanted to talk about assessing collateral ventilation with the Chartis system. So on the day of the procedure, when you are under general anesthesia and are undergoing the bronchoscopy, we always perform this test before valve placement to evaluate for collateral ventilation. We insert a balloon into airways going into the target lobe to ensure no air. This confirms what the StratX report printout tells us. As we all know, technology can only tell us so much, so we have to physically evaluate the accuracy of that.
The PulmonX Chartis system provides precise pulmonary flow and pressure readings, allowing physicians to assess the patient's collateral ventilation. By identifying diseased lobes with no collateral airflow, physicians can optimize the valve placement for endoscopic lung volume reduction.
All right, some really great information. Let's go ahead and take a little short brain break and do another poll question. Which basic test is required to determine eligibility for this procedure? Pulmonary function testing, a CT scan, pulmonary rehab, or both A and B? Okay, see the answers. The correct answer is both A and B, pulmonary function testing and a CT scan.
Okay. So this shows you why Chartis is important. So we treat patients with accuracy. Relying on fissure analysis alone on the StratX report results in actually CV patients trying to be treated and CV patients being untreated. So we always want to avoid that. So that's the benefit of that Chartis system. This is again an overview of the sequential process of endobronchial lung volume reduction. So of course we go through the clinical screening and the testing first. And if that all looks good, then we proceed with bronchoscopy with lobe and fissure evaluation to make sure again that StratX report is accurate. And then of course we treat with the valves. After the procedure. So if a patient does not pass the Chartis assessment due to having collateral ventilation, then they go home that same day and it's an outpatient procedure. But if they do pass the assessment, then the valves are placed. On average, 4 to 6 valves are typically placed, but this is very much based on a person's individual anatomy. And the valve insertion results in a 3-day hospital admission at Franciscan Health Indianapolis. And the reason for that is because the biggest risk or potential side effect to this is a pneumothorax, which is why we do keep you in the hospital. It occurs at a rate of 30% within the first 3 days post-procedurally. And a pneumothorax is an air leak in the lungs that occurs as the treated lobe collapses and the remaining lobes compensate for the change. It can result in placement of a chest tube. It does not adversely change the success of the procedure compared to someone who does not develop a pneumothorax. This means that the benefits will still be the same once the pneumothorax has resolved. Most common post-procedural symptoms other than the pneumothorax, so what patients have told us or what we have reviewed, is a cough with pink tinged sputum, chest discomfort due to the remodeling of the lungs as the treated lobe reduces in size, and also increased fatigue. But once you get discharged from the hospital, we do have you rest at home for about a month, and then we have you restart pulmonary rehab, which will allow you to experience the greatest benefits. Of course, Dr. Khan and I follow with you closely after discharge in our interventional pulmonology clinic at the Indianapolis campus. Okay, patient-reported benefits. Compared to control patients, Zephyr-treated patients reported reduced breathlessness across multiple measures, greater ability to do activities like bathing and household chores, fewer limitations in returning to work, more energy, and more confidence in leaving home overall. Meaningful improvement was seen at 45 days post-procedurally on average. So for some people, the benefits are not always immediate. Sometimes they are gradual, but they do occur over time for most people. This procedure is clinically accepted globally with over 15,000 people treated, more every day. And as mentioned before, it is now accepted within national and international medical guidelines. And this last slide shows some disqualifying factors for valve placement. So just a brief overview of that. Someone is not a candidate if they've been told in the past for some reason, maybe related to a heart condition, that they cannot undergo a bronchoscopy under general anesthesia. People who have active and frequent pulmonary infections, typically, we would not want to exacerbate an infection by placing valves in. So that's one indication. Known allergies to nickel, titanium, or other metals. If you're a smoker, or if you have large bullae in your lung greater than 30%. And bullae is not something that most people know that they have in their lungs. That's a great question for your lung doctor if you're interested in this procedure, is to ask about having a large permanent air-filled space in your lungs, which can sometimes happen with emphysema. And then at our facility specifically, we are not treating alpha-1 deficiency patients at this time, but other facilities are that are doing this procedure. All right, thank you all for listening to this portion of the webinar tonight.
Thank you, Abby, for your expertise and providing so much education to us on COPD. Now I'd like to play a video for you where our interventional pulmonologist, Dr. Faisal Khan, will discuss how a one-time minimally invasive bronchoscopy procedure can improve the quality of your life with less shortness of breath and more energy.
LVRS is basically lung volume reduction surgery. So it's achieving the same results through surgical means that has been in practice for a few years now, done at specialized centers. And the idea is the same to remove the disease portion of the lung. So if you have already had a lung volume reduction surgery, the chances are that you're not a good candidate for reconsideration through the valve. It's a one-time procedure. The procedure can vary from half an hour to 1 hour, and it depends because the procedure has 2 steps to it. Prior to the procedure, you have determined they're a good candidate, their CT scan and everything else looks promising, their breathing numbers look promising. So then the next step is to establish whether they are collateral ventilation negative in the lobe of the lung you want to target to block. So that is the first part of the procedure. So when we start the procedure, for patient, it's the same experience. They're under anesthesia. We go in and we do our assessment of that lobe, whether the collateral ventilation is negative or not. And if that is negative, then we end up putting a valve. So if the valve, if the collateral ventilation is not negative, it's positive, then that patient is not a good candidate and we do not put a valve. So in that case, half an hour. If we end up putting a valve, maximum half hour more. So total maximum 1 hour procedure. They can be removed easily. It's a bronchoscopic procedure. Removing them is generally not a big issue. Can they migrate and be coughed up? Yes, if the valve is undersized, that can happen, but the incidence of that is very rare. We have been placing valves in the lung for almost 5 years. Okay, that was a different valve for a slightly different indication. But the technique of placing the valve is exactly the same, whether it's the other valve or the Zephyr valve. Zephyr valve got approved last year by FDA, and we started the program this year at Franciscan in July. You can imagine this is not a one-time procedure. So I think with Franciscan Health, the program we have, it gives me a lot of pride that the system we have set up is designed to take ownership of the patient from the very start when the referral is made all the way throughout their journey for this procedure and even months after. We have a whole team of navigator, a nurse practitioner, myself, and then our staff in the procedure room is dedicated to these kind of procedures. So for patient, anytime they have any question or concerns, they are welcome to call our navigator or the nurse practitioner, and they can always reach out to me as well to answer their concerns. And as they go through different testing, there is a detailed communication back to them by our team of where we are, what the test showed, whether they're a candidate, whether they're not, if they're not, why they're not a candidate. And the other thing is we make a point that we are communicating with the referring physician. So most of these patients are already being seen by other lung doctors. And our goal is not to take over the general care of their lung disease. Our goal is just to be a resource for this procedure as such and a resource to their doctors. So we are in constant communication throughout the process with their primary physician and their primary pulmonologist. And any issues that might arise, we communicate with them. So it's an experience not only for the patient, but for the referring physicians. And if the referring physicians have any concerns or they don't agree with our decision making, then we are open to that critique. And I personally make a point of calling them and having a communication. So the good old saying, when people talk, good things happen. That's our motto, so to speak. And I think that makes us different from any solo practice or individual doing this procedure, because it's just not one procedure. It's the whole bigger picture that revolves around it. So this procedure is approved by Medicare. Medicare covers it. Private insurers, most of them do cover it. Some of them would want to go into an appeal process where there's a peer-to-peer review between myself or my team and the physician on the insurance company side. And if you have crossed all T's and dotted all I's, generally they approve it. As regards to the out-of-pocket cost, that is on individual's insurance plan, the details of those. So they need to, everyone has to check with their insurance what their out-of-pocket cost is going to be. But in general, this is an approved procedure.
Thank you. I hope you found that video overview educational. Let's do one more poll question before we move on to our Q&A session. COPD is a chronic lung disease which includes bronchitis and emphysema. True or false? Okay, let's see what you said. Yes, the correct answer is true. Okay, now we'd like to take any questions you might have for Abby about COPD or the Zephyr valve. So please type in your questions in the Q&A chat box, and I will read them to Abby and she will answer them. We do have a couple that I'll go ahead and read as the rest of you go ahead and fill in your questions or type them in the chat box. So Abby, the question is, what if I have LVRS?
Yeah, so LVRS, if you've already had that lung volume reduction surgery, meaning that you've had a part of your lung cut out, we typically do not then retreat. That is essentially the same thing, only that was more of an invasive process. So if you've had the lung volume reduction surgery done before, chances are, just based on the anatomy, looking at the lungs again, you would not be a candidate again for this minimally invasive procedure.
Okay. Another one. I have been diagnosed with a bleb in my lung. Would this be good for someone like myself?
So a bleb is probably a bulla, which is again a large permanent air-filled sac in the lung. And really, it could be, this procedure could be, but it would just really depend on how big that bulla is. And if it's close to another part of the lung that's weak or not, it would not just initially rule you out for being a candidate for this or not, though, but we would have to do more testing to see.
Okay. Getting quite a few questions in, so keep them going. I also have sleep apnea and chronic heart failure, diabetes, and AFib. Am I still a candidate?
So multiple comorbidities really just depends on if they're well controlled, how extensive the heart failure is. So really anything below an ejection fraction, which most patients, of course, we don't know what our ejection fraction is, but below a certain number, which in our case would be 45%. So a left ventricular ejection fraction below 45% would put someone at a risk to undergo general anesthesia. And would likely not be a safe procedure in that case. But diabetes does not rule someone out as long as that's controlled. And sleep apnea, as long as you're compliant with your CPAP machine at night, that is also not a disqualifying factor.
Okay, thank you. I'm on oxygen 24/7. Is that a problem?
Most of our patients are on oxygen. Some patients are on 5 to 6 liters. Some patients aren't on oxygen at all, but we do have a lot that are on oxygen 24/7. So no, that is not a disqualifying factor. That's actually most of our patient population.
Okay. How far in between procedures if you need another one?
So really a second procedure would be based on how well you did on your first procedure. So if we achieved occlusion with the first procedure, then we don't have to go back in and revise. Now, the two parts that we were talking about in the presentation, those happen together. So you don't get woken up if you pass the Chartis assessment. It's all within the same go. So I'm not sure if that's what you were talking about. But in regards to, doing the Chartis assessment and then the valve placement, that's all within the same time period, all within the same procedure. Spacing out from two separate procedures, hopefully you wouldn't have to have a revision. But if so, that can happen as early as a month or two, just based on how you responded or if there was any complications with the procedure.
Okay, and to kind of follow up with that question, Abby, she also asked, how many procedures can you have total?
So we treat once. So we treat one lobe of the lung. So one side of the lung, based on what that StratX report shows us, one destructed lobe of the lung. And it would be hopefully a one-time procedure. Now, if you have a couple different lobes, maybe one destructed lobe on each side of your chest, on the right and left side, there is talk that eventually, if you do receive benefit with treating one side, that we could in the future treat a second site on the other side of the chest. But that is not something that we have done yet, or that we've been far enough into the program to do yet. So we are about a year out right now from our first Zephyr valve being treated. So essentially, hopefully not more than one procedure initially, and then could be in the future just based on that StratX report.
Okay. I use I'm not sure I'm going to say this right, nitrile inhaler, but have been smoke-free for 6 months. Would this disqualify me?
It does not disqualify you. We would just need to have proof that, again, you're on that type of inhaler prescribed to you by a doctor. And again, that's something that's managed by someone and monitored by someone. So no, it's just one of those things that, one bad apple spoils the whole tree, if you've heard that saying. So we just really want to make sure, again, that The candidates that we do get, of course, aren't smoking because that further damages the lungs. So again, with the appropriate documentation, that's not an issue at all.
Okay. Do patients do well enough and not need oxygen after the procedure?
We do have some patients that have come off their oxygen completely. It doesn't happen for everyone, and it's very individualistic. But we do monitor that based on 6-minute walk tests, and oxygen evaluation before you would leave the hospital after your 3-day stay. And again, some people, they have reduced oxygen requirements. So some people that were on 3 may only need 1. Some patients that were on oxygen at rest may need none, but still need it with walking. It's very individualized. And also some people don't come off their oxygen or stay on the same needs, but they subjectively feel better. They don't have that shortness of breath or have to take rest breaks as they did before.
Okay. What is the average percentage of increased lung volume?
Increased lung volume. So we will, well, it's the inverse. So we actually take away, we're hoping to take away 50% of the lung volume. So we're trying to reduce the volume of the most destructed lung. So anything that we consider clinically significant in our world, we're trying to reduce that lobe by 50% or greater, and hopefully 100%. So with that reduction of the most destructed lobe, you're going to get potentially more volume in the rest of your lungs that have been squished from that damaged part.
Okay. How would I find out if I'm ruled out because of this blub in my right lung? I was told that my lung could collapse if not treated. Is this true?
So where we have everybody start is talking to your lung doctor, and kind of seeing what that, what they mean by that, or, you know, getting potentially a referral to us. And if we, you know, can take a look of the chest CT and tell someone if they would be a candidate or not based on blebs in the lung. So essentially, you know, either talking to your lung doctor about it, or getting a referral to us, and we can take a look at the chest CT and see, you know, specifically what your situation is and if you would potentially be able to be treated with this or not. The reason that it's contraindicated is because if you treat a side of the lung that has a big bleb, it could potentially result in that lung collapse or that pneumothorax that we talked about, and potentially not heal. So blebs are very, very delicate air spaces. And if we do too much manipulation to it, in certain instances based on your anatomy, then you could potentially have permanent lung leak. And we obviously do not want to do that. We don't want to be more harmful than beneficial to anybody.
Thank you, Abby. It says, a couple questions. I've been diagnosed with COPD on 24-hour oxygen, but have not seen a pulmonologist. How do I get referred?
Yeah, so anybody that's a candidate for this procedure needs to be on medical inhalers. So typically maximum inhaler therapy, start with that, and then we can always potentially look into then the Zephyr valves. But if you're seeing a family doctor and they have you on maximum inhalers and you're taking inhalers already, then you can actually just ask your family doctor for a referral to our office. But if you don't have anybody treating you at all with any inhalers, that would be the first part. And that actually significantly helps so many people that are on oxygen, but maybe not treated for their COPD with any type of medications. That's the first step. And that really is a super helpful step for people experiencing this that aren't treated.
Okay. If I've had a pneumothorax before, would I still qualify?
It would depend on the reason for the pneumothorax, but typically if you've already had a pneumothorax on the side that we would treat, we would not be able to treat that side. That's not to say that your other part of your chest or your other lung is not a candidate, but typically if you've already experienced a pneumothorax on the side that we would treat, you have a lot of scar tissue potentially, and that could be a disqualifying factor. It would just depend on your specific case, but it could be, or it could not be. There's always more than one area of the chest to go to for our lungs.
Okay, take a few more minutes to answer any questions that anyone might still have. These have all been great questions.
Yeah, these are all great.
Abby, I know you mentioned this a little bit earlier, but do you want to walk through the process again for those who are on the webinar to let them know how to go ahead and talk to their doctor or make that referral to your office?
Yeah, of course. So we're located here at Franciscan Health Indianapolis within the hospital in the outpatient center. And a lot of the times, what Dr. Khan really prefers is that you speak to your lung doctor first and say, hey, I've listened to a webinar, I've got some information on these valves. What do you think? Asking your lung doctor what their thoughts are. And then, they then will refer you to our clinic, or you can ask them for a referral. And this is fast, and then you tell them his name, Faisal Khan. And then typically then we get that referral here at Franciscan Health Indianapolis. So as time goes on with this procedure, it wasn't well known a couple years ago, but as time kind of moves on, this is getting out there more. And when you go to your lung doctor, and kind of say, hey, this is what I'm thinking, they're going to have an idea of what you're talking about. A couple years ago, they may not have, but now they should have more information on it. Or if not, they can refer you to us and we can make that decision on whether this would be something to consider or not. But again, this is something that we want to consider when you're already on inhalers and there's really nothing else that the doctor can tell you that they can do, or any other medication management that they can provide for you.
Thank you. And earlier, Abby, I mentioned that we have a nurse navigator dedicated to the IP program. Can you explain a little bit about what Laura's role is?
Yeah, so Laura Halterman is our nurse navigator, and she really identifies with all of our patients. She calls, updates, does a lot of the navigation. If you're kind of confused in the healthcare system, especially when it comes to all of this, which can be very confusing. The medical world is definitely not easy to navigate. She helps, get everybody to the right spot, whether that be numbers or helping, get to the specific or right person. And, if you want to go through this process and you're, kind of confused on where to start, please call our office, and Laura or Claire, she's another one of our nurse navigators. We can kind of talk you through things and get you to the right person. So they're really just that middleman between all the crazy chaos that happens with healthcare, and especially with your lungs, as that being a chronic condition that can be very anxiety provoking, of course, and cause a lot of stress. So Laura and also Claire are kind of go-to people to talk to within our clinic.
Wonderful. We had a couple questions come in since you've been
Yeah.
talking. One is since this is a new procedure, how many successful procedures has Dr. Khan done?
Yeah, so we started this program in June, probably end of June, July of last year, which was kind of an interesting time to really get the program up and running because of the COVID pandemic. And of course, this being a procedure that really targets the population that was affected the most with COVID, it's kind of limited the amount of procedures that we've actually been able to do, meaning that we had kind of a period of time in which Franciscan Health was not allowing us to do any elective procedures, or procedures that weren't considered essential. So we have treated 17 patients successfully. And really that number is very varied by the fact that if someone doesn't come to us in pulmonary rehab, they have to be in pulmonary rehab for 6 weeks. Prior to that changing, we actually had patients in pulmonary rehab for 3 months. We've actually modified that based on Medicare guidelines and private insurance guidelines and what they will actually pay for. And so the process on average for each person to kind of go from start to finish with finding out that they're a candidate, they get through their pulmonary rehab, is about a time span of 2 months. So with that being said, we've treated 16 patients successfully, and we actually have more on the schedule. I think like 9 or 10 more that are ready to go back for the procedure within the next couple of months.
Okay. If you aren't on oxygen full time, are you still a candidate?
Yes. So really, oxygen is one of those things that we don't use that as a disqualifying factor. It really, depending on what your pulmonary function testing looks like, those numbers that we talked about during the presentation or that were on that slide, that's really the qualifying factor. And the oxygen is, just kind of one of those things incidentally that most of our patients are on, but it's definitely not a qualifying or disqualifying factor.
Okay, well, thank you, Abby. Is there anything else you'd like to say before we wrap up our webinar this evening?
We are happy to talk to anybody that has further questions, concerns about this procedure. Within the resources that you should be getting after this presentation should be our number. So please call us and we are happy to kind of answer whatever else that you have or get you in the right direction. And if you don't have a lung doctor, we can get you referred or help you get a lung doctor.
Wonderful. Thank you so much. Thank you, Abby, for sharing all this great information, and to each of you for attending this evening's webinar on better understanding COPD and the treatments we offer. We understand that your time is valuable, so thank you so much for prioritizing your health to spend some time with us this evening. Once again, we'll send you an email with the recording of this session, and feel free to watch it again or share it with others who might find it helpful. But before you go, I wanted to share with you a free wellness challenge that Franciscan launched recently. You may have seen it. It's called the Do Good, Feel Good 30-Day Challenge that focuses on you through simple daily mind and body activities. Just taking a few minutes a day on each challenge will change the way you think and increase your happiness. It's easy to sign up. Just go to the website on the screen or text GOOD, G-O-O-D, to 26464 and pick a start date. The challenges are simple and non-intimidating, and they apply to all ages. Friends and family can join with you. It's a good way to start your journey toward a healthier you in mind, body, and spirit. So on behalf of everyone at Franciscan Health, thank you for being with us and have a blessed day.